Greetings, everyone. Thank you for inviting me for this presentation. In the next few minutes, which I'm going to cover, the most important word in my topic will be finding people with TB. I think that's the most important word because that's where we are losing pace or losing ground. And hence, if at all we would like to realistically achieve the target of ending tuberculosis and AIDS, both the epidemics together, then we have 54 months left to do that. And if we can pick up pace in finding more people quickly using the existing tools, we should be able to meet our targets and goals. So we are not failing at finding at treatment. We are not failing at treatment. We are basically failing at finding. And TB is the leading cause of death amongst people living with HIV. Around half of the people in the community with bacteriologically confirmed tuberculosis report no symptoms when they are screened. As a result, symptom-only screening is not going to work. We are going to miss many tuberculosis cases unless and until we don't add a chest X-ray to this. Treatment will save lives and it is saving lives, but it can only help once we identify the people having tuberculosis. Chest X-ray finds these. Reading it is where the bottleneck is. So if you see, WHO recommends chest X-ray alongside the 4-symptom screen for people who are living with HIV. It raises the sensitivity of screening and helps rule out tuberculosis before starting any preventive therapy. For people on antiretroviral therapy, it is the most sensitive screening strategy available. But what held it back is that every chest X-ray needs to be read by an expert. Unfortunately, in most high burden settings, there is no radiologist available to support HIV clinics. Images wait for days to weeks to get reported, and sometimes they're not even reported at all. And even when they're reported, there will be time and moments where the readers will disagree most often than we would like to admit. And for decades, the limiting factor for TB screening has not been the chest X-ray, but the availability of an expert to read them. However, this has changed with the availability of CAD products, computer-aided detection tools, which can screen a chest X-ray for tuberculosis and multiple other lung conditions within less than 30 seconds, completely offline. The policy barrier has already come down for using these CAD products. In June 2025, WHO recommended and endorsed 6 CAD products that met the target performance profile. TPP performance standard set for TB screening. CAD removes the need for an on-site reader, one of the biggest hurdle for tuberculosis screening. It eliminates the inter-reader variability and it delivers the results within seconds at the point of care. Literally, by the time the patient changes their clothes, the results should be available. As a result, a positive CAD result indicates the need for a confirmatory test before treatment. So once the CAD is used, you basically use it as a screening tool and not a diagnostic tool. And since 2021, WHO has recommended these computer-aided detection AI reading of the chest X-ray as an alternative to human interpretation for TB screening and triage. The recommendation covers all adults aged 15 years and over, and it explicitly includes people living with HIV. So this is no longer a pilot question because in Tamil Nadu state alone, in India, one of the most populous states, along with other states as well, AI read chest X-ray started with the Greater Chennai Corporation, moved to a few districts, then moved to 6 districts. Now 15 districts are covered, and more than 2 million people have been screened using this. In Tamil Nadu alone, it should be around 500,000 people from 2019, out of which 56,000 individuals were studied over a period of 1 year as a part of this cohort, and where it has been able to be demonstrated like a twofold increase in TB diagnosis compared to the standard pathway. Almost same number of people, the same program, but a different way of finding them. A 60% reduction in cost per quali. Cost effectiveness threshold CET lowered by 94% with AI interventions. indicating that AI interventions to be highly cost effective. And this is published as a research paper as a AI CAD enhances pulmonary TB detection and yield in active case finding, and this covers the entire study. These are the vans in which the screening is done, and this is how the operator handles the laptops on which the AI results are available after the patient has been X-rayed. But this is not limited to Tamil Nadu alone. This is a global deployments are seen. More than 2 million people screen as a part of the global deployments, where portable and ultra portable X-ray devices, along with the AI, which is a CAD solution, has been deployed in more than 450 plus sites across India. But this is not only India, Africa, Southeast Asia, right up to Mongolia. Every nation, including UK, is using these tools. Whether it is in public healthcare settings, whether there's high transmission risk, where we have undiagnosed cases, where there's limited access to experts, in certain sections of the community, even in prisons. There have been projects with Global Fund projects with Alliance India and also projects with UCL London along with NHS UK. And now the part which we do not say often, but it needs to be discussed, is that the computer-aided detection tools, performance and accuracy in people living with HIV and those with prior TB, it definitely needs additional assessment. This is why thresholds which have been calibrated locally and not inherited from vendors needs to be considered. And this is a solvable problem because only if programs start adopting chest X-ray AI with CAD solutions, they can calibrate, they can learn from the experience, and then they can calibrate locally, and then they can share these results. So 3 moves available to us right now is that screen where people already receive the care. Integrate the chest X-ray AI with CAD into routine HIV clinic visits without waiting for radiologists to become available. Calibrate for the population. Establish and publish the CAD threshold specifically for people living with HIV. Invest in the subgroup evaluation that remains scarce. Lastly, but not the least and the most important, is close the pediatric gap. CAD is not yet recommended for children under 15 years of age. Children living with HIV remain among the most underserved population across the TB care pathway. None of these require new science. All this requires is action. We have 54 months left. Finding people with TB remains the slowest gap in the care cascade. Yet it is the one step which when effective tools already being available, if used well and at pace, and using the current policy, which is already supporting the use, we will be able to meet our targets. So finally, in conclusion, we already have the tools to find TB, particularly for people living with HIV. What remains is the decision to use them and to ensure that they work as well for people living with HIV as they do for everyone else. Thank you so much for your time. And if the last concluding message being, if we are able to enhance the pace of finding TB using this technology, I think we have done a job. Thank you so much.